Good evening, sir. So, shall we start? All the aspirants have joined us. Many will join us too.
I guess so, because it's going to be a long session.
Okay,
I've
sir.
tried to go through five case vignettes. I have not gone through the classical route about having everything as TF and everything because the amount of information is so vast that I think you will need to cover that first, and then only we can make some questions out of it. I've tried to
Okay, sir.
file in a case vignette in which there are five sub questions.
Okay, sir. So, shall we start?
Sure.
Good evening, all the aspirants. Today's topic is organ donation and transplant. And the faculty that we have here is Dr. Nikhilesh Jain, sir. He is the Director and Operational Head, Department of Critical Care Services at CHL Hospital, Indore. Sir, you may continue. Thank you.
Right. So we look at the first case. And I may be going slightly fast because we are supposed to cover five cases today. You've got a 54-year-old man, decompensated NASH cirrhosis, MELD score of 32, undergoes deceased donor orthotopic liver transplantation. This guy is admitted to ICU, intubated on low dose norepinephrine. Initial labs showed a pH of 7.32, lactates of 3.8, millimole per liter, INR of 2.1, platelets of 60,000, AST, ALT values in the range of 1500 to 1200, bilirubin of 7 milligram per deciliter, mean arterial pressure of 65 mm mercury, and a urine output of zero point 0.4 mils per kg per hour. Okay, so this would be the first case, and we'll expand and build upon this further as we go down, going into certain other questions. So, what are the key immediate post-operative goals for this particular patient in the first 24 hours? So, what do you think would be the three priority systems that you would like to stabilize? What would be your targets for MAP, that is mean arterial pressure and urine output? What would be the immediate labs that you would like to trend in the first 6 to 12 hours? What would be the key aspects of graft function monitoring that you would like to do? And what are the two important communication points with surgical team that you would like to have on your plate? So these are the questions that are going to be there. Okay.
Yes, sir. Yes, sir.
Okay. I do understand that transplant is not an easy topic and there may be certain issues. So that is there. Okay. What I'll do is I'll take on the answers myself, not a problem at all. So when we go for the answers, what are the three priority systems to stabilize? They are mainly hemodynamics, graft function, ventilation, and oxygenation. What would be your hemodynamic targets and urine output targets? Mean arterial pressure of more than or equal to 65 to 70 mm of mercury. Urine output of more than or equal to zero point 0.5 mils per kg per hour. What are the investigations that you would like to trend? Investigations that you would like to do in the first 6 to 12 hours, that is ABG with lactate, full liver panels, INRs, and APTT, CBC, electrolytes, creatinine, and of course, sugar levels. Uh, Key aspects, how would you monitor the graft function? You would look at trends in lactate, INRs, your transaminases values, bilirubin, bile output, and of course, you'll do a hepatic ultrasound Doppler here. Okay. When it comes to getting some information from the surgical team, you would need to find out about the exact interop events. You know, you need to find out what were the clamping times, what were there any transfusion complications, and is there any concern they would like to have about the graft quality or the type of anastomosis done, because this would have implications for your future management of these patients. Okay. Now, how do you assess and manage his hemodynamics? You expect two invasive lines. Why do you want two invasive lines? Is there any utility of dynamic indices of fluid responsiveness? How a cirrhotic cardiomyopathy would impact your vasoactive choice? Will it impact or not impact? What would be the role and risk of aggressive volume boluses or fluid boluses? Any two markers which actually can suggest an ongoing hypoperfusion despite a mean arterial pressure of 65 mm of mercury, right? This is the second part of the first case vignette. And when we go through this, the answers would be arterial line, actually beat to beat BP, of course, arterial blood gases intermittently, and central venous line, wherein you can use it for vasopressors, monitoring CVP SOS, and of course, sampling purposes. When it comes to dynamic indices, stroke volume variation or pulse pressure variation can actually guide the fluids. But be cautious if you see concurrent arrhythmias, if the patient is getting ventilated on low tidal volumes, or if the patient has got an open chest or abdomen. When it comes to cirrhotic cardiomyopathy, it has got a blunted inotropic response. So you preferably the drug of choice would be norepinephrine as first line, and you can add dobutamine or epinephrine if there is a concurrent low cardiac output. If you're going to give aggressive fluids, then what would happen is there can be graft congestion, there can be an abdominal compartment syndrome, you can get a pulmonary edema. So ideal is to use small guided boluses and then see how the response is. Regarding what all other things you would need to monitor would be even if your mean arterial pressures are around 65, would be rising lactates, low central venous oxygen saturations, and of course, cool peripheries, low urine output, and mental status changes. These are the things that you will need to look at when you're talking about such a patient of liver transplant. Now, eventually, he develops rising lactate and an INR, which is gradually rising over a course of about 12 hours. So the important questions that can come at this point in time would be define the primary non-function of the liver graft. Can you tell us about two early clinical or lab features which suggest a primary non-functioning liver graft? You look at two vascular causes of acute graft dysfunction. What would be your first line imaging and key findings that you would like to confirm? And what are going to be your management principles if you are actually able to confirm your primary non-function of the liver graft? Okay. So going through this, it is basically irreversible graft failure within first week without technical cause, and it requires an urgent retransplant. Now, what would you look at? Two early clinical or lab features which will suggest you a primary non-functioning of the liver graft. So you would look at rising lactates, you would look at worsening coagulopathies, INR of more than 2.5. You would look at minimal bile outputs in these patients, patients going into encephalopathy, and of course, hemodynamic instability. The other complications that you would need to look out for would be hepatic artery thrombosis and portal vein thrombosis. When it comes to first line imaging and key finding that you would be trying to find out would be on a Doppler ultrasound. You would try to look for absent or abnormal hepatic artery or a portal vein flow. And if this happens, then you need to go in for aggressive organ support. And of course, this type of a patient has to be urgently listed for a retransplant procedure as far as liver transplant is concerned. What about nutrition and metabolic care in the first 48 to 72 hours? What should be your timing of initiation of nutrition? What would be the preferred initial route if gut is functional? What would be the two key metabolic issues that you would like to monitor? What would be your strategy for glycemic control? And two reasons why early post liver transplant actually overfeeding would be harmful. So, going into the answers, you start your feeding within 24 to 48 hours if your patient is hemodynamically stable. Start on early enteral nutrition, which would be preferable via nasogastric tube or a orogastric tube if there is no contraindication. Look for complications like hypo or hyperglycemia, specifically dyserythrolytemia of phosphate, magnesium, and potassium, as there is a risk of refeeding. When it comes to glycemic control, use an IV insulin infusion and target your values between 140 to 180. The other things that you would like to look at, if you look at two reasons, overfeeding is harmful early post liver transplant. So it increases, overfeeding increases your carbon dioxide production and ventilatory demand. So what it leads to is hepatic steatosis and impaired graft recovery in these particular patients. Now this patient is started on tacrolimus, mycophenolate and steroids, which is a common enough regimen for all these patients. So what are two common early infectious complications after liver transplant? That is what we need to know. What is the common empiric antimicrobial coverage you would like to give on day 0 to 3 in terms of broad principles? What is the drug level that must be monitored and why do you think it should be done? Of course, what are the two signs acute, suggesting that there has been an acute cellular rejection of the graft in ICU? Basic management steps if you're suspecting acute rejection. So things that you suspect here would be bacterial pneumonia, surgical site or line or abdominal infections, and later on, you can think in terms of either a cytomegalovirus infection or a fungal infection. The antibiotics that you would like to use here would be a broad spectrum anti-pseudomonal beta-lactam with or without a MRSA coverage, with or without an antifungal, depending on the risk as well as the local ecology. Now, the levels that are required to be done are tacrolimus or calcineurin inhibitor levels. It is because it has got a narrow therapeutic window. It goes in very fast for nephrotoxicity or neurotoxicity. What you would monitor would be rising bilirubin and transaminases, cholestasis, fever, which can be very minimal at times, and graft tenderness if it is seen or if it is evaluated. When it comes to this, you discuss with transplant team, you confirm this with imaging and biopsy, increase the steroids and adjust the immunosuppression for this particular patient. This is the second case. What we did first was a liver transplant variant. So this would be another thing. So this is a 42-year-old woman with diabetic nephropathy on hemodialysis and undergoes a deceased donor kidney transplant. On post-op day 1, she is in ICU with persistent oliguria to the tune of 0.2 mils per kg per hour, creatinine of 7.8 milligram per deciliter, potassium of 5.9 millimoles per liter, and there is mild pulmonary edema. So how do you define, rather, you need to assess, excuse me, the delayed graft function here. You define delayed graft function. What are the two donor-related risk factors for delayed graft function? Two recipient factors for ICU admission after a renal transplant. Two non-immune causes of delayed. Somebody said something? Okay. So two non-immune causes of delayed graft function and two immune causes of early graft dysfunction. This is what we need to know. When it comes to defining delayed graft function, that is basically need for dialysis within the first week post-transplant. That is what is the most common definition. When it comes to risk factors, it is basically an advanced donor age along with a prolonged cold ischemia time for the kidney. Now, what you are looking at is hemodynamic instability and significant comorbidities when it comes to two recipient factors for ICU admission after renal transplant. When it comes to two non-immune causes that you want to rule out would be acute tubular necrosis, renal artery or vein thrombosis, any form of obstruction to the ureter, and of course, hypotension. Now, with modern cross-matching, acute rejection and a hyperacute rejection is what you would like to rule out, but it is rare once the current rules for modern cross-matching have come in place. So that is something that you should know. When it comes to managing your oliguria and pulmonary edema, what would be your key hemodynamic target for renal perfusion? What is the role of CVP or dynamic assessments in renal transplant patients? What would be your approach to fluids versus diuretics in this scenario? What would be the two common indications to start renal replacement therapy in ICU post-renal transplant? And what would be the precaution that you would like to use when you're doing ultrafiltration in a new graft? So answers would be like MAP should be ideally more than or equal to 65 to 70 mmHg. You can use it higher if the patient has been chronically hypertensive. You can use CVP or dynamic indices both in this type of situation to avoid both hypovolemia, which can lead to graft ischemia, along with overload, which can lead to pulmonary edema. Preferable again, as in liver transplant, would be small guided fluid challenges. You should be very cautious with your loop diuretics trial and try to avoid volume overload or fluid overload. Now, when it comes to what would be the indications of RRT or renal replacement therapy, it would be a refractory hyperkalemia. It would be a pulmonary edema with ongoing hypoxia, severe acidosis, along with uremic symptoms. These are common indications for renal replacement therapy. And when it comes to precautions during RRT, that would be avoiding aggressive volume removal, which can actually compromise graft perfusion and systemic blood pressure. When it comes to imaging and biopsy, what would be the first imaging test if you think in terms of a low urine output post-renal transplant? What are the two key findings that you should be looking for? What are the role of Doppler indices? When do you actually plan to do a graft biopsy? And what are the two precautions that you would like to do before biopsy? Okay. Answers would be an ultrasound with Doppler of transplant kidney. You want to look at hydronephrosis or any form of obstruction along with renal artery or vein thrombosis and any perinephric collections. If you've got an elevated resistive index, we've covered it in AKI. that is more than zero point 0.8 suggests increased vascular resistance. It is not specific for the, it's not a specific finding, but it's a supportive finding. Then again, persistent delayed graft function, despite optimized hemodynamics to differentiate acute tubular necrosis versus rejection. Of course, you would check the coagulation and platelets, control the blood pressure of these patients, and ensure there is no evidence of any uncontrolled infection which is ongoing at this point in time. What about balancing immunosuppression when you're talking about delayed graft function? So typical triple drug regimen is used. Uh, what would be the typical drug regimen? That is what you would look at. What would be the calcineurin inhibitor related renal complication that you should be considering? And of course, how DGF may alter dosing of calcineurin inhibitors. What are the two drugs which are commonly adjusted or held if your patient acquires sepsis at this point in time? And of course, you should know one non-renal organ toxicity of tacrolimus. So the drugs that would be used as triple regimen would be calcineurin inhibitors in the form of either tacrolimus or cyclosporin, anti-proliferative drugs in the form of either mycophenolate mofetil or azathioprine, and along with that, steroids. Vasoconstriction mediated nephrotoxicity is what you would like to look at, which is manifested as a rise in creatinine in these patients. When it comes to what you would like to do, you need to delay or you need to lower the dose of these immunosuppressive agents, and you do very close level monitoring to avoid the nephrotoxicity. Uh, Mycophenolate mofetil or azathioprine and sometimes calcineurin inhibitor, that is tacrolimus or cyclosporin inhibitor, they are temporarily reduced under the guidance of transplant team. And the common problem that happens with tacrolimus would be neurotoxicity, and it is manifest as either tremor, seizures, and of course encephalopathy. Sometimes this encephalopathy can even manifest as a psychotic reaction, and they may be dubbed as the patients of delirium. So that needs to be sorted out. With an ongoing dialysis and infection risk, what are the two common early infections in renal transplant patients? What is the prophylaxis that you would like to commonly use against these opportunistic infections? What would be your nutritional goal for protein intake post renal transplant where there's no rejection? What would be the effect of steroids on glycemic control and what would you like to do about it? What would be the two infection control measures which would be specific to renal transplant ICU patients? So what you would like to do is rule out catheter-related bloodstream infection, pneumonia, and urinary tract infection. The drugs that would be commonly implemented here would be cotrimoxazole or valganciclovir as per protocol. The type of supplementation that you would like to use, nutritional goal for protein intake, that would be around 1 to 1.3 gram per kg per day. If the patient has more stress and if there's a higher catabolic stage that you're thinking about, you can go up further. Steroids cause hyperglycemia. The target levels remain 140 to 180. It needs insulin therapy and close monitoring. Then you minimize the invasive lines, strict hand hygiene, try to avoid unnecessary Foley's or central lines. And if your patient becomes neutropenic, please put them in protective isolation. This would be the third case that we would be doing. A 30-year-old man with acute myeloid leukemia, 14 plus days post allogeneic hematopoietic stem cell transplantation, presents with fever, hypoxia, and hypotension. You've got an absolute neutrophil count of 0.1 into 10 raised to power 9 per liter, platelets of 12,000, hemoglobin of 8.2, creatinine of 1, and bilirubin of 1.4. Now you do a chest X-ray for this particular patient, and it shows you bilateral patchy infiltrates. So when it comes to ICU admission and resuscitation, what would be the two common indications for ICU admission after doing a hematopoietic stem cell transplantation? What would be the immediate ABC priorities? What would be the initial sepsis-oriented investigations that you would like to do? What are two risk factors for poor ICU outcomes post stem cell transplantations? And what would be the prognostic scoring consideration that you would think about when you are dealing with these particular patients? So common answers would be respiratory failure and septic shock. Also, encephalopathy can happen along with severe graft versus host disease and bleeding. Um, Secure your airway and ensure oxygenation, ensure circulation with fluids for vasopressors, and establish monitoring and lines. The investigations that you do would be blood cultures, urine cultures, sputum or bowel where feasible, chest X-ray or CT chest on an SOS basis, lactates, your ABGs, and food labs. The risk factors would be prolonged neutropenia, multi-organ failure, along with refractory shock. And of course, when it comes to using scores, you can use SOFA. Now you've even got SOFA, the newer version of SOFA that has come in now. And of course, Apache 2 and Apache 3 scores can be used. Higher scores are actually associated with higher mortality. When it comes to respiratory and hemodynamic monitoring, what are the two radiological differentials for bilateral infiltrates that you would think about in this particular patient? He's got an ANC low, he's got a platelet count which is low. Role of CT chest versus chest X-ray. What would be your two hemodynamic goals in septic shock here? Um, is there any value attached to doing lactate values repeatedly and looking at the trends? And when would you like to consider echocardiogram? So answers would be bacterial or viral or fungal pneumonia, ARDS, pulmonary edema or diffuse alveolar hemorrhage. CT chest any day would offer a better characterization specifically of nodules, halocyon, and organizing pneumonia. Chest X-ray can be done initial, but it has limited value. The hemodynamic targets that you would be looking at would be MAP more than or equal to 65 mm of mercury, adequate oxygenation, target your SpO2 levels to more than or equal to 92% unless you are with a ARDS strategy. Adequate urine output in the form of more than zero point 0.5 mils per kg per hour. If you've got a falling lactate, the indicator that you would like you would like to look at would be a falling lactate, which would suggest that perfusion is getting better. If you've got a rising or a plateaued lactate, it indicates ongoing hypoperfusion. Now, when shock is refractory, try to assess LV-RV function, pericardial effusion, and of course, volume status. When it comes to neutropenic sepsis and infections, what should be your empiric antimicrobial strategy? What do you think would be your add-on coverage for suspected fungal infection? What are the two most important viral pathogens in post-stem cell transplantation patients? What would be your microbiology sampling precautions? Because these patients would be having severe thrombocytopenia. If you remember, our patient also has 12,000 only. And what is the role of prophylactic antimicrobials for these particular patients? So answers would be probably using a broad spectrum anti-pseudomonal beta-lactam with or without an aminoglycoside or fluoroquinolone is good. Consider MRSA coverage on a case-to-case basis based on the risks involved. When it comes to using antifungals, you can use echinocandins or voriconazole for invasive candidiasis or aspergillosis. The viruses that you would look at would be cytomegalovirus, respiratory syncytial virus, and other respiratory viruses, adenovirus, and of course Epstein-Barr virus. The precaution that you would like to use would be giving platelet transfusions before doing any invasive procedures and try using ultrasound guidance. When it comes to using other drugs, fluoroquinolones, azoles, acyclovir, cotrimoxazole, they would all decrease infections, but they will never eliminate infections. So breakthrough infections are common, and these are risk factors. So graft versus host disease and sinusoidal obstruction syndrome. So what would be your typical organs which are involved in acute graft versus host disease? What are symptoms suggesting acute graft versus host disease in ICU? What are the features suggestive of sinusoidal obstruction system or VOD of liver? Mainstay treatment for acute GVHD, and of course, supportive ICU measures for severe GVHD. So main things that we need to look at are skin, liver, and gut. What you get is a rash, profuse watery diarrhea, liver dysfunction, and abdominal pain. And of course, the other thing, for occlusion, SOS, you get a painful hepatomegaly, weight gain, ascites, and rising bilirubin along with fluid retention. What you need to do is try to use high-dose systemic steroids and additional immunosuppressants as per protocol. How you would actually use your fluids would be aggressive volume balance control, nutritional support, often in the form of parenteral nutrition, and these are all common infection control measures, infection surveillance, analgesia, and organ support. When it comes to nutrition in a neutropenic critically ill, what would be your preferred route of nutrition? When would you consider when would you consider parenteral nutrition? What would be the two specific nutritional challenges in severe mucositis or GI graft versus host disease? You look at protein and calorie targets in general ICU and two non-nutritional supportive measures, which would be crucial for stem cell transplantation ICU patients. So answers wise, it would be enteral nutrition any day would be safer and it would be better if gut is functional and safe. The complications that can be seen now here would be severe mucositis, ileus, graft versus host disease with malabsorption or risk of perforation. What you can get is odynophagia, malabsorption, or diarrhea leading to electrolyte loss and negative balance. The calorie targets would be roughly 25 to 30 kcal per kg per day and protein target of 1.3 to 1.5 gram per kg per day, depending on the individual. And you can individualize this. Try using strict infection control or protective isolation, transfusion support in the form of RBCs or platelets, and of course, stress ulcer and VT prophylaxis as appropriate, not in all patients. Case 4, this is a multi-organ transplant. Your ICU admits 3 transplant patients simultaneously. So it gets more, murky. So now what you have got is a day 5 post-lung transplant patient with rising bilirubin and fever. You've got a day 4 post-renal transplant patient with sudden anuria and graft tenderness. You've got day 20 post stem cell transplantation patient with rash and diarrhea, and you are asked to review them for all possible immunological complications. Okay. How would you differentiate acute rejection? You need to know 2 clinical features of acute liver rejection. You need to know 2 clinical features of acute renal rejection. What would be the timing of acute cellular rejection post-transplant? And if there's one lab pattern that favors rejection over biliary obstruction in liver transplant, what would be your diagnostic gold standard for solid organ rejection? So rising transaminases of bilirubin along with graft tenderness along with some mild fever, that would be indicative of acute liver rejection. Rising creat, decreased urine output, graft tenderness again, and again sometimes fever. This would be of pertaining to renal transplant failure. When it happens, timing of typical acute cellular rejection post-transplant, usually it is days to weeks after transplant, but it can be earlier or later. Then what you get in liver transplant would be a disproportionate rise in transaminases and bilirubin without seeing any dilated ducts on imaging. And of course, histological confirmation is confirmatory. It is done by taking a graft biopsy. Any more severe immunological injuries? Yes, you need to define hyperacute rejection. What are the type of mechanisms involved? What would be the clinical course in renal transplant? What are the 3 treatments for antibody-mediated rejection? And what would be your preventive strategy that you would practice pre-transplant if you were to avoid these? So immediate graft failure occurring minutes to hours due to pre-existing antibodies, you know. So this is within minutes to hours, immediate graft failure. This is what is referred to as hyperacute rejection. Preformed donor-specific anti-HLA antibodies, which are IgG in nature, and of course complement activation. They are the culprits which go behind it. What you can get is sudden anuria, swelling of the graft, severe hypertension, which requires graft removal. The treatment line that you would follow would be high-dose steroids, plasmapheresis, IVIG, with or without rituximab and other biologics. And of course, the precautions that you would like to take would be to do a proper cross-match testing. You need to do a DSA screening and you try to avoid incompatible donors or desensitization. Day 20, post stem cell transplantation rash and diarrhea. So there are two key differentials. This is actually acute graft versus host disease. You need to do what would be your basic diagnostic tests, what would be the first line therapy, and what would be the infection risk implication of escalating the immunosuppression. So the two key differentials would be, of course, an acute GVHD is first that you would like to rule out because that is more dangerous and bad. You look for drug reactions, you look for viral exanthems, you look for infectious colitis in the form of C. diff and CMV. You look at for a confluent maculopapular rash, which involves the palms and soles. If there's significant watery diarrhea and there are abnormal liver function tests, you do a skin biopsy, you do a colonoscopy with biopsy. Of course, you do your liver function tests and viral PCRs. Treatment here would be high-dose systemic steroids. And of course, it markedly increases the risk of opportunistic infections. So what you would need is prophylaxis and surveillance for both of them. What about sepsis in transplant recipients? You look at general principles of immunosuppression adjustment in sepsis. What would be they? What are the 2 agents which are often reduced or held first? Why calcineurin inhibitors are not always stopped? What is the importance of drug-drug interaction with the azoles? And what would be the one ICU strategy that you would need to monitor for under immunosuppression? Okay. So temporarily, you reduce the intensity while avoiding precipitating a rejection or graft versus host disease. Try to individualize with the transplant team. You use anti-proliferative agents, sometimes mTOR inhibitors. These are the most common two agents that are reduced or held back. That is the mycophenolate mofetil or azathioprine. And when it comes to reduction of dose, which are the ones where calcineurin inhibitors, when we talk about why is a dose reduction required. Now, most of the times, common calcineurin inhibitors that are used in these type of settings are tacrolimus and cyclosporin. So, abrupt withdrawal may precipitate rejection, and so dose is gradually reduced with a close level monitoring. Azole antifungals, if you use, they inhibit the cytochrome P3A4. So that would actually increase the levels of tacrolimus and cyclosporin. So you need to adjust your dose and monitor the levels. And when it comes to monitoring, what you would need to monitor would be serial LFTs along with creatinine, graft, Doppler, or biopsy if it is indicated on an SOS basis. And of course, you monitor these patients for graft versus host disease signs. Pulmonary complications, what would be the two immunological causes of lung infiltrates post-transplant? What are the two infectious causes unique or common in the setting of lung transplant? What would be the role of bronchoalveolar lavage in differentiating that? What would be one radiological clue to organizing pneumonia versus bacterial pneumonia? And how steroid therapy can both help as well as harm here. So basically, when we talk about here, two immunological causes of lung infiltrates post-transplant. So one is, of course, acute ejection. Of course, organizing pneumonia is second one. And then there's a delayed reaction here and immune deconstitution, pneumonitis here. Of course, pneumocystis, Girovecchi pneumonia, invasive aspergillosis, CMV pneumonitis, and nocardia are the culprits that you need to look out for. If you do a bronchoalveolar lavage, it allows for microbiological diagnosis. And what it does with that would be um, sometimes you need to do cytology for DAH in, of course, your lung transplant patients. Okay. Uh, then peripheral or bilateral patchy consolidations or reverse halo pattern, uh, which is more typical of organizing pneumonia versus lobar consolidation. And of course, steroids, which can treat immune mediated lung injury, but it can worsen infection risk and may mass. Okay. So here, what we are looking at is one is, of course, differentiating with from infection. The peripheral and bilateral patchy consolidations, a reverse halo pattern, more typical of OP versus lobar consolidation. Sometimes cytology for, what you need to do is DAH, because I have not put the full form here, certain of you may be having a query. DAH is nothing but diffuse alveolar hemorrhage. So that is what can happen as a complication post lung transplant. This is a final case. 48-year-old woman, end stage interstitial lung disease. Day one post bilateral lung transplant. She is getting ventilated on FiO2s of 0.6 with PEEP 8 and PF ratios of 180. Now she needs norepinephrine of zero point 0.1 microgram per kg per minute and chest X-ray is suggestive of bilateral diffuse infiltrates. And then your priorities in first 24 hours after lung transplant would be two major respiratory goals. What you would be looking at. What are the hemodynamic targets and key concerns for right ventricle? What would be the role of early bronchoscopy? What are the two common immediate post-op complications? And what would be your key ventilator strategy principle here? Answers wise, what you would look for, what you would attempt would be adequate oxygenation and ventilation, prevention of atelectasis and aspiration. Hemodynamic targets wise, you try to maintain a mean arterial pressure of more than or equal to 65 to 70 while avoiding pulmonary hypertension. You protect your right ventricle from volume or pressure overload. You check for airway anastomosis integrity, mucus plugs, and bleeding. if feasible, obtain cultures. What you would need to watch out for would be primary graft dysfunction, bleeding, reperfusion injury, along with arrhythmias. The ventilatory strategy that you would practice here would be a lung protective ventilation of about 6 mils per kg of predicted body weight, along with appropriate PEEP. That is what you are looking at. Now she has PF ratio of 180 with diffuse infiltrates. So we need to define your primary graft dysfunction. You need to know the risk factors for primary graft dysfunction. What would be the distinguishing investigation for primary graft dysfunction versus cardiogenic pulmonary edema? What would you like to do in terms of basic management of moderate to severe primary graft dysfunction? And when would you like to consider ECMO for these particular patients? So if you have acute lung injury within first 72 hours post-transplant, which is not explained by other causes and is manifested by hypoxemia and radiographic infiltrates, it's basically you're talking about rejection here, or what we refer to as primary graft dysfunction. How you would differentiate it would be, or the common risk factors that may be present there would be high FiO2 during the reperfusion, if the patient has had a prolonged ischemia time, if the recipient had had pulmonary hypertension, and if the patient has got a very high body mass index. How you would do an assessment would be echocardiography or hemodynamic assessment to differentiate between cardiogenic pulmonary edema and this, because obviously you'll be looking at RV and RV functions and filling pressures. If they are high, more likely to be cardiogenic. If not, then more likely to be primary pulmonary. You would practice lung protective ventilation with adequate PEEP, conservative fluids, vasopressors on an SOS basis as needed, and treat the contributing factors. And when we look at refractory hypoxemia or severe graft dysfunction, despite maximal conventional support, that is when you would like to practice or use your ECMO machine. Specifically VV ECMO first. If you've got a concurrent cardiac dysfunction, please go ahead and use VA. Then the question comes about monitoring lungs and circulation. So what are the radiological features that worry you about anastomotic complications? What would be the role of CT versus chest X-ray the first week? What would be the common RV failure signs that you would need to know after doing a lung transplant? Do you think that you can use a pulmonary artery catheter or echo in this setting? And what would be your fluid management principles in early post-lung transplant? So what we would be looking at would be radiological features that worry you about anastomotic complications, would be focal collapse distal to anastomosis, any air leaks, any localized consolidation near the hilum, and of course, any mediastinal shifts. When it comes to CT versus chest X-ray can be done for daily overview. CT can be done for suspected anastomotic problems, emboli, or unclear infiltrates. When it comes to looking at your RVs, so elevated CVP, hypotension, low urine outputs, and echo showing a dilated RV with poor function is what you need to visualize and look at. How you would actually use your pulmonary artery catheter or echo in this type of setting, what we discussed earlier were RV failure signs, of course. So you would need to actually titrate your vasodilators and inotropes accordingly. Either use a PA catheter or an echo-guided pulmonary pressures here. When it comes to giving fluids, try to use a conservative fluid strategy to avoid pulmonary edema and, of course, graft dysfunction. Use vasopressors or inotropes rather than using large fluid boluses. What about immunosuppression and infection? Why lung transplant has a particularly high infection risk? What are the two early pathogens that you would like to cover empirically? Excuse me, what are the two immunological causes of hypoxia after the first week? How acute lung rejection is diagnosed, and what would be the basic treatment of acute lung rejection? So answers would be, why is because allograft is directly exposed to environment, there's impaired lymphatic drainage, and there's a very high immunosuppressive burden. So very likely, with a very high likelihood of patient getting infected here. What you would like to cover would be hospital or ventilator associated gram-negative bacilli, and of course MRSA. Fungal can be plus minus depending on the risk. Then again, how would you actually two immunological causes of hypoxia after the first week? So immunological causes wise, you would be looking at acute rejection, BOOP or bronchiolitis obliterans organizing pneumonia after first week, and also antibody mediated rejection. How you would be able to identify clinical picture plus radiology, and of course you need to do a transbronchial lung biopsy here. How you would treat it, you need to go in for high dose IV steroids and adjust your maintenance immunosuppression under the guidance of transplant physicians or surgeons. Okay, this was the large case scenario, and I've just added one more slide, namely pertaining to ECMO. So ECMO indications, and this is specifically for lung transplant. Pre-transplant PF ratios of less than 80 for more than 6 hours is what you're looking at. That is an ECMO indication. If your PaCO2s are more than 80 of mercury with pH of less than 7.2, then again it is a ECMO indication. This is all VV. If you have a concurrent cardiac dysfunction, you have to say VA. Post-transplant, again graft dysfunction grade 3 with PF ratios of less than 100 on FiO2 of more than or equal to 0.8 with PEEP more than or equal to 10. Or you get a severe hypercapnia with respiratory acidosis and a reperfusion injury, which leads to severe pulmonary edema. In late post-transplant patients, in those patients who develop antibody-mediated rejection and airway complications in the form of an asthmatic leak, collapse, these are the type of patients who would need to go on ECMO. Again, preferably VV, and if you have got concurrent cardiac dysfunction, VA. Okay, so these are the two things that would be there. Going into it further, what would be happening here is that a pertinent question that is asked sometimes is how would you declare a patient brain dead on ECMO? So first of all, we all know that there's something called as sweep gas flow, and of course there's another thing called as temperature. The flows are maintained at a definite temperature, so there can be temperature variations. That is one thing that can confound your brain dead declaration. And second thing, of course, you need to come down on your sweep flows, sweep gas flows, so that gradually you are able to achieve a sense of normalcy. Then put these patients on TPs, and preferably then you do your apnea test and everything. The rest of the things remain the same. However, there may be patients whom you may not be able to do these things at all. These patients may be very unstable. So in those patients, if you can do imaging, that would be great. That is difficult, but if you can do it, then doing a CT angio or doing an absolutely silent EEG and using them as ancillary tests would be very good. You can, label these patients as brain dead based on those particular tests in that particular setting. And of course, certain places they are also using transcranial Doppler now. Not very accurate. But if there's nothing that works, maybe that can be done. Oh, I'm sorry, excuse me, if I was very long-winded. It was a huge topic, and to cover it within this duration meant I had to go slightly fast, and that is what has happened here. So this is done. Any questions? I mean, there may be many, I'm very sure. I've tried to cover most of the salient points of different solid organ transplant as well as stem cell transplants, which can come as questions. Hopefully, most of this would be covered in this. This is an absolute silence. Am I audible?
Yes, sir.
Okay, okay, okay. Okay, was the subject content too heavy?
Yes, Dr. Nikhilesh. The post-transplant, it was very interesting, and fortunately or unfortunate, it's mathematics. 1 + 1 is equal to 2. So there is not much of questions. Where this one was exemplary and very refreshing.
Okay, I'm assuming this has been recorded, so this recording would be there with you people, and Sana would have recorded it, and you can access this at a later time as well if you think you need to come back to it.
Yes, thank you, Doctor.
Okay, I'll close the session, Sana, then.
Thank you very much, sir. The session was very informative. Thanks a lot.
Okay, thank you, everyone.